We have started the meeting, and we will wait just a couple of minutes to get started to let a few more people join. I see the participant number is going up still, so let's just wait a minute or two. We won't wait too long because we have a lot on the agenda today. Thanks for joining. Okay, welcome everyone. Let's get started. So could we have the next slide, please? And my name is Paul Barnett with the Behavioral Health Administration, and this is our brief agenda for the day. I'm now going to pass it to Lisa Madrigal to give us housekeeping information.
Hello, and thank you, Paul. Thank you for joining us today. We are expecting a large audience. Therefore, everyone has been muted. To reduce background noise, make sure you're muted when you're not speaking. If you have a question throughout the presentation, you are welcome to use the chat or use Zoom's raise hand feature. Questions will be addressed by the chat moderator when it's appropriate. If you have an opportunity to speak, we kindly ask that you introduce yourself and your agency. We have ASL interpreters. They are Kimberly, Adrian, and possibly Audrey. You will see that title next to their name. So it would be Kimberly S., ASL interpreter, Adrian, and then Audrey. During the event, you can spotlight our ASL interpreters so they will appear larger on your screen. You have the ability to change your view at any time. In the upper right-hand corner of your screen is a view button. Use this to toggle between speaker view and gallery view. You can also hover over the right corner of the ASL interpreter video and select Pin if you would like to see them large on your screen. Back to you, Paul.
Thanks, Lisa. Now I want to introduce Webster Hendricks, who's going to cover our mission and purpose. And go ahead, Webster.
Good afternoon, and again, welcome. And I am wanting to remind you of the BHA's mission and the goals that we have put together in order to achieve that mission. Our mission in the BHA is to co-create a people-first behavioral health system that meets the needs of all people in Colorado. In order to accomplish this mission, we have developed the following values: collaboration, working in partnership to realize a holistic behavioral health vision, community-informed practice, integrating evidence-based guidance with lived expertise, equity, naming root causes of injustices and allocating the necessary resources to support desired outcomes, generational impact, engaging in meaningful and thoughtful action to create a new legacy, and truth, being transparent and accurate when addressing the people of Colorado. Please join us in that mission and these values. Paul?
Thanks, Webster. Now I'd like to introduce Summer Othercole, our Deputy Commissioner of Operations.
Thanks, Paul, and good afternoon, everybody. Thanks so much for joining us today. Unfortunately, our interim commissioner, Michelle Barnes, could not join us. She is actually speaking at an event on the Western Slope, but just wanted to welcome all of you. As you saw, we have a packed agenda today, so lots of good things to discuss and talk about with all of you. One kind of update or announcement I wanted to share, and hopefully many of you have seen that we have begun recruiting for our permanent commissioner. And so that position has been posted. I will put it here in the chat in a minute so everybody can see that. We're also going through a little bit of a reorg, and we are recruiting for a deputy commissioner position as well. So we can put the link to that in the chat box as well. But we need good, strong people. I want to ask all of you to share those positions with your networks, help us find the right people for these positions so that the BHA can continue its really good work. So I also want to recognize, I know, like I said, Interim Commissioner Barnes is not here. Chris Meyer is our Senior Advisor for Children, Youth, and Families as part of the executive leadership team as well. And I think with that, Paul, I will hand it back over to you.
Thanks, Summer. And just in the interest of time, I'm going to introduce our statewide program directors and the provider convening team rather than go through each of us. So again, my name is Paul Barnett. My pronouns are he, him. I'm the Director of Child, Youth, and Family Services here. Also, we will have a Director of Workforce Development in the near future. Our Interim Director of Criminal Justice Services is Danielle Culp. Director of Adult Treatment and Recovery is Mark Condajani. And our Director of Care Coordination is Heather Pash. Our provider convening team, the people behind the scenes who make all this work right, I include Melissa Morales, Des Allen, Lisa Madrigal, Marina Borisov, and Webster Hendricks. Thanks everyone for your help. So I'd now like to introduce our first speaker, and that is Heather Colwell. She is the Director of Government Relations, and she's going to talk about the Health Information Exchange.
Thanks, Paul. Good afternoon. My name is Heather Colwell, and I'm happy to be joining you today. Like Paul said, I am the Director of Government Relations at Contexture. I'm happy to be talking to you about Contexture, the Health Information Exchange, and our partnership with the Behavioral Health Administration on the Medication Consistency Program, in which we are assisting correctional facilities connecting to the HIE. Next slide, please. So the Medication Consistency Program was born out of Senate Bill 17019 in 2017. From this bill, the purpose was to improve access to effective medications for people who transfer in and out of criminal justice. And this includes mental health facilities, mental health institutes, jails, and prisons. So Contexture has been working closely with the Office of Behavioral Health, now the BHA, on this program since 2018. We are assisting correctional facilities to access Patient Care 360, which is our longitudinal health record. Next slide, please. So I want to talk a little bit about how the Health Information Exchange works. So HIE stands for Health Information Exchange. So on this slide, you can see all of the different participants that are contributing their data to the Health Information Exchange. So a little background about Contexture. We are formerly Creo, so you probably are familiar with that name in Colorado. But we joined forces with the Arizona HIE in 2021, and we formed a regional health information exchange where we are connected to more than 1,800 organizations now in 2 states. So we have 77 approximately 100 providers and over 2,200 HIE users in Colorado, and we serve over 8.9 million unique patients. The HIE provides valuable data for improving care and quality and improves healthcare for the community. Health Information Exchange allows healthcare professionals to appropriately access and securely share patients' vital medical information electronically. The HIE receives data from many different sources, including public health departments, hospitals, correctional facilities, labs, radiology, and physicians. Hospitals contribute their data, including ADT information, transcription notes, labs, radiology results. We also get laboratory results from all of the major labs and radiology reports, including some imaging links. We also have care summary documents from ambulatory providers, including the, as well as the Department of Defense, the Veterans Administration, Kaiser, as well as QHN, which is our sister HIE on the Western Slope. Next slide, please. So here you can see a map of Colorado, and this is showing the work that we've done in coordination with the Behavioral Health Administration over the last 5 years of this medication consistency program. So we have connected with 31 county jails, and we have 2 additional jails that are pending go live. Next slide, please. This slide shows the bigger picture as we also work with QHN, our sister HIE on the Western Slope. So here you can see the 31 jails that are connected to Contexture, as well as the 11 jails that are connected to QHN. I'd also like to highlight that we have 5 jails that are connected bidirectionally, which means they are sending their data to us upon inmate release so that we can populate that into the longitudinal health record for access as well. Next slide, please. So Patient Care 360 is Creo or Contexture's online portal where facilities, medical staff can access patients' medical data. Within Patient Care 360, you will find information about demographics, lab results, radiology reports, ED encounters, discharge summaries, just to name a few. We've currently also added a pilot program under this medication consistency program, where we're offering access to medication filled data available via query. Patient Care 360 users now access care summaries for community providers, and they can also retrieve consolidated summary encounters over from the last 12 months of a patient's encounters. Next slide, please. So I spoke briefly to the bidirectional piece on the slide with the map. This slide outlines that process a little bit more. So in terms of supporting the correctional facilities in contributing their data to the HIE, we are intaking a continuity of care document. So this continuity of care document, or a CCD, is an electronic document that summarizes patient information to help providers communicate clinical information during transitions of care. So the CCD is a standardized document template for transferring patient information between care settings, and it includes information about their demographics, medications, allergies, procedures, encounters, labs, and diagnoses. A CCD is sent to Contexture upon inmate release from the correctional facility. So this triggers the CCD to then hit our system, and then that is populated in Patient Care 360, and that's available for the provider on the other side to be looking at. Next slide, please. So I also wanted to speak a little bit to the pilot program where we are granting access to the clinical vendors in these county jails to look at the medication filled data. So this is a new feature in Patient Care 360 available only to these providers because this data is quite expensive. And so we are looking for funding to try and expand this out to other providers, but currently the providers in the clinical setting and the jails are able to query this filled medication data. Next slide, please. So this is just a deeper dive of what that medication will look like. So you can see it would show the actual medication itself, the facility and the pharmacy where it was filled at, who it was prescribed by, etc. So we have found great results with several of our county jail facilities accessing this information, and would be excited to roll this out. Next slide, please. So here you can see my information. I would like to take the opportunity to just highlight the impact of health information exchange By sharing data at the point of care, it really supports the information sharing for the next provider caring for the patient and vice versa. We are also excited to announce that we are beginning a pilot program to launch a new consent platform to exchange 42 CFR data. We would love to partner with this community about this critical data sharing. Please reach out to myself, or I will also drop the name of our director of sales who's working on this pilot as well into the chat, and we look forward to talking to you soon. Thanks so much.
Thanks so much, Heather. And now I'd like to introduce our next speaker. That's Brianna Hurd. She's the program manager for our SAMHSA State Opioid Response Grant.
Thank you, Paul. Good afternoon. I am Brianna Hurd. I'm the Harm Reduction and Treatment Program Manager for the State Opioid Response Grant, housed in Adult and Treatment and Recovery at BHA. So let's start with what is a medication unit. It is a smaller census opioid treatment program that offers medication for opioid use disorder. These include methadone, buprenorphine, and Sublocade. Providers may also choose to offer Vivitrol. I will explain our call out of expanding MOUD access, review prohibited expenses, followed by allowable expenses. And on the final slide, there will be 2 links on how to be notified when the request for funding proposal is released. Any questions or concerns that you share in the chat during this presentation will help inform the SOR team and the MSOs in writing the RFP. So this particular, go back a slide, please. Thank you. This particular project is a call out from our grant source, which is SAMHSA, as means to expand medication for opioid use disorder. This aligns with a few of our other projects like mobile health units, which serve rural areas by prescribing buprenorphine, offering peer support, care navigation, and providing some harm reduction supplies like naloxone or fentanyl test strips. At this time, we will exclude Region 2, which is the Denver metro region, due to the current number of OTPs already in the area. We do understand that there are pockets of limited or no access in the Denver region. So if for whatever reason we do not receive an adequate number of applicants for our rural regions, we will consider opening up the RFP to Region 2. Because a med unit is a smaller census clinic, it may not be appropriate to have a standalone clinic. Med units can be affixed or in partnership with community health centers, hospitals, pharmacies, behavioral health clinics, or even jails or justice-based programs. I want to point this out specifically because our colleagues at Jail-Based Behavioral Services are working to assist jails with meeting legislation set forth by House Bill 1326, or the fentanyl bill, which requires jails to offer MOUD, or medications for opioid use disorder. Partnerships are particularly advantageous to a project like this because of the long-term need for sustainability. These are medications that people need to take daily, and we need to be mindful of that, which is why we really need to think about sustainability and partnerships so that we're not doing startup funds for a clinic only to have that clinic go away in a few months, and then we're leaving people without medications that keep them safe and healthy and alive. We've budgeted for about 4 units across the state at about $80,000 each in startup funds. Technical assistance is provided by SAMHSA, the SOR team, so myself, and the BHA licensing team. Next slide, please. So usually I like to start with allowable expenses under this grant. However, for this, I found it really useful to actually start with what SAMHSA will not fund. So first is the facility purchase. We can't just buy a building. No construction of a new structure or expanding on an existing space, a vehicle purchase, staff salaries. We do understand that staffing is a challenge right now, and we're hoping that alleviating startup costs helps opioid treatment programs remove some of the burden of starting up a med unit. This is also why we're encouraging partnerships amongst interested parties. Promotional items, please note that promotional items does not include marketing such as flyers or advertising. I did talk to our GPO about this because that was confusing to me. This is more in lines of promotional items like swag, but wouldn't include things like flyering. And as always, SAMHSA wants everyone to know that we can't pay for medical marijuana or syringes meant for injecting drugs. Next slide, please. So I will read off the allowable expenses for those who are calling in. Facility rent and lease, a security door, dosing window, dosing furniture, chairs and tables, observation door, security cameras, electronics install, medication dispensing software. There are two that are most commonly used. Dosing machines, including the pump and the dispensing supplies, PPE, your personal protective equipment, medication safe, medical refrigerator, sharps, containers, printers. There are a few items that are stipulated or explicit permission only. So minor A&R, which are alterations and renovations, which are a little different than expanding on a structure, so to speak. Window installations, which are separated from minor A&R. And then medications. So those medications need to have a documentation of offset from other funding. So that would be cash, Medicaid, and private insurance, because the SOR grant is the payer of last resort. Next slide. So the RFP will be written by the MSO, so Signal, Diversis, and then Rocky. Rocky does not have a link on their website for proposals. The proposal will include all three MSOs, so all regions except for Region 2. And those two links, both Signal and Diversis, will link the RFP. And if you have any questions, you can email me on, which will be posted. And then you could also send something in the chat and I can save that question. Thank you.
Thanks very much, Brianna. Now I'd like to introduce our next two speakers, Robin Warner and Bonnie Jortberg with the University of Colorado School of Medicine. They're going to talk about fentanyl education, Colorado.
Thanks, Paul, and hi, everyone. I'm Robin Warner, and we're here to talk about the Fentanyl Education Colorado website, which is fentanyledcolorado.org. This is part of the Colorado State Legislature's education plan within the Fentanyl Accountability and Prevention Act. The platform and curriculum were developed to meet the need of court-ordered learners that need to demonstrate they've taken the course. Furthermore, the site offers a module for trainers to help think through how the education could be offered to court-ordered learners in various settings and scenarios. I was going to ask if anybody in the audience could raise their hand to see, using your meeting controls, to see if you have accessed the site. I didn't expect such a large audience, so that might be really, really hard for me to see. But if you have accessed the site, either as an observer, as a trainer, and want to put anything in the chat, that would be great. Next slide, please. Okay, I'm going to do a quick run through, a live run through of the course material and the features for trainers, but I also want to invite you to access the website and the learning opportunities anytime if you haven't already. So you go to fentanyledcolorado.org. And then the next step is to select your trainer type. And I'll show you this in just a moment, but I really wanted to make a note that we have a lot of learners coming to the site that are selecting, I have a personal interest, which is kind of our general catch-all for the public. And I think a lot of those learners are actually probably trainers based on their email addresses. So the trainer selection is that I will provide fentanyl education. I just wanted to make a note that if in doubt and you're a partner with a BHA or whatever, I would definitely choose that you will be providing fentanyl education instead of I have a personal interest, because that will allow you to see the course for court-ordered learners as well as the trainer module, which you may need and or find interesting. The second point I want to make there is that if you have registered as I have a personal interest and you want to be changed to a trainer, our contact information is at the last slide of our presentation here, and we can easily change your registration type to the trainer course or cohort, if you will, so that you can see that. So next slide, please. A benefit to the trainer module, which is called How to Present Fentanyl Education, is simply that it helps you think through the various scenarios and setups that may help you provide this education opportunity to court-ordered learners. So there are additional features such as being able to add a learner, which I will demonstrate in a moment, and downloading materials to provide to court-ordered learners. All right, I think we're going to give it a go. That I'm going to share my screen now. And we were hoping this would go super. There we go. Okay, so this is the website, fentanyledcolorado.org. And with this website, we have incorporated a number of videos for people to have lived experience with fentanyl and fentanyl addiction. So we invite you to watch the video here on the homepage, but then know that there are other videos embedded within the learning opportunities that get into the specifics of their experiences. So just something to note other than reading, and this is both for you as trainers as well as court-ordered learners. The site is completely available in English and Spanish. So all downloaded materials, all online materials are available in both languages. Once you've registered for the site, which I won't show you at this time, but registration is very straightforward and easy, basic registration information. You're directed to my account page, which I'm showing right now. This is a trainer view. So fentanyl education is the course that court-ordered learners need to take. And then how to present is the trainer module. These additional features I will demonstrate here for you in a moment, but adding a learner, downloading certificate, and downloading materials as well. First, though, I will just take you on a really quick drive through the course. This is for court-ordered learners. And there are many sections that have a lot of subtopics within them, including Colorado's new laws with fentanyl, risk reduction, and other treatment modalities and facilities and resources and that sort of thing. Again, this is really helpful for trainers and court-ordered learners to have all of the information, and there are downloadable resources that encapsulate each one of those higher learning opportunities that are available for trainers and court-ordered learners as well. This is just a random page that I chose to show you. Again, it has a video of a person that has lived experiences with fentanyl, and as well as other tips. We have two PowerPoints in here that go over, administering naloxone and various other things as well that might be helpful for trainers and or colleagues of trainers. Okay, so now I'm going to switch gears and go into the trainer module, and I won't.
Robin?
Yeah, sure.
I'm sorry.
Oh.
Hi, everyone. I'm Bonnie Jorberg. I work with Robin. I just want to make one comment about the content of the module for the learners, and that is that all of the content was actually mandated as part of the Colorado legislation. And I say that because we certainly always appreciate feedback from our trainers and users and those kinds of things about the content. But just to know that it was very prescriptive in the legislation in terms of what this module needed to address and the topics that needed to be addressed through the legislation. So I just wanted to mention that, because if you're going through and saying, why are you putting all this stuff about the laws in there? It's because this was actually part of the legislation of what we needed to include. And this actually had to be approved, that we met all the requirements of the Colorado legislature in terms of what they put into the bill. So I just wanted to mention that.
Thank you. No, I appreciate it. in the trainer module here on how to present fentanyl education. I'm not going to go through it. Again, we invite you to go through it, but I do want to point out that the purpose of this module is really to help think through all of the different situations or scenarios that that fentanyl education might be used within your facility or agency. So we have broken things down really as thinking about this of a one-to-one, if you are working with one court-ordered learner or maybe with 1 to 2 individuals, and how you could do that. And this takes into account several things. This takes into account perhaps this person may or may not have an email account. And for an online learning opportunity, you need to have an email account. So we go through various steps for what can be done in those situations. So there's always a workaround. There's not anybody that's really left behind from the standpoint of not having such thing as an email address. But then there's also group learning formats that are discussed in this e-learning module. So various situations and setups for that. Ending with a trainer attestation that just says you have looked at the course for fentanyl education, because it's hard to administer the course without being familiar with the course, as well as this e-learning module that's available. Okay, so that is the site in a quick nutshell, and we're going to switch back to the slides. Thank you. Okay, so we are in the process of also trying to create a I don't want to call it a partnership, but an opportunity to have the fentanyl education available through tablets in the jail community. So through Secure Us, which many of you may be familiar with. That is not a formal deal yet, but we understand that having access within jails is a challenge, and we're trying to help work through that. We had previously designed this so that thinking that a projector could be used to show the online learning module in person. Oops, I just realized I forgot to show you the Add a Learner. I'm so sorry, I forgot my notes, but on the online platform, as you register as a trainer, you see that there's the Add a Learner button. I showed that to you on the My Account page. That allows you to take that person's information and input them just as if they were interacting with the learning opportunity themselves. So you get their information, and we provide a downloadable form for you to collect the exact information, and then you transfer that and input it into the system. That way, our database can capture all of the court-ordered learners, and then you can provide them with a complete certificate of completion. I'm sorry, I forgot that one element there. Bonnie, you look like you have something to say. Did you have something?
Oh, I was just going to say, and maybe that is a really important component, especially if they're court-ordered learners, because it's the only way in which we have a record, because we provide all of the data to the Behavioral Health Administration so that they can then provide that information to the state for the court-ordered learners that they have actually completed this learning opportunity, completed this module. So it is really important that if you do have court-ordered learners, that you need to, as a trainer, they don't have an email address, or you're not actually giving them actual access to a computer or a tablet, that you do upload their information, because again, that's the only way that we have a record that they have completed the course.
That's correct. So I would love to share some data with you for today. So we launched the site on January 1st, 2023. And since that time, we have had over approximately 440 learners. 7 of them are court-ordered learners. So not that many court-ordered learners, but of that 7, 4 of them were input in the way that we were just describing. So it was a trainer that added these learners through this add a learner feature to show that they had done or completed the education. And then a breakdown of trainers and general public is split evenly, with about 200 or just over 200 per cohort. So trainers and general publics. And again, I mentioned that we think that a lot of the general public learners are very likely should be trainers. So something to note if you're telling your colleagues about the site is to choose the I will be providing to cover that base. So that wraps up our data to date, and we're seeing more court order learners now. Our first court ordered learner came in late April. So we're just, we had a lag time from when the law took effect to when court order learners were starting to, hear about and be told that they needed to access this education opportunity. And now we're starting to see a pickup in court order learners. And next slide. So the contact at fentanyledcolorado.org is a general inbox that we can field any of your questions. Karen is the fentanyl education manager for BHA. And then Bonnie and I are from, again, the University of Colorado Department of Family Medicine. We're happy to answer any questions anytime. Thank you.
Thank you, Robin and Bonnie, very much for that. We can go to the next slide. And before I introduce our next speakers, I just want to say we're somewhat ahead of schedule, so I don't want anybody to feel rushed from here on out going through their presentations. So now I'd like to introduce Joanne Toney, the Director of Clinical Services with WellPower, and Kelly Reedford, our Program Manager of Trauma-Informed System of Care here at the BHA, and they're going to talk about trauma-informed design.
Thanks so much, Paul. I was all prepared to talk quickly, so I'll slow my roll a little bit. Thanks, everyone. You can go to the next slide. All right, briefly, I just want to do an introduction on trauma-informed care. I know that it's definitely become very popular, especially in the mental health field in recent years. And there's definitely been tons of initiatives and push for agencies and systems to become trauma-informed. So I'm going to talk a little bit about what trauma-informed care is, and then the subspecialty, I think, trauma-informed design. Trauma-informed care is a program, organization, or system that is trauma-informed. It realizes the widespread impact of trauma and understands potential paths for recovery, recognizes signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So that's a ton. And I want to encourage everyone to think, I think a lot of times when we think about trauma-informed care, we think about a clinician or someone who works with people in services, and trauma-informed care is the way that they deliver their services. And I want to encourage people to think more broadly about that, and thinking about trauma-informed care as a system, trauma-informed care as a program, as more broad than just how someone performs or delivers services. And thinking about trauma-informed design, it is designing a building to help regulate the body, support therapeutic approaches, create a feeling of beauty, connection, physical and psychological safety, a feeling of control and empowerment for the individual, particularly for the individual in services, but also for staff. It's very important to think about this not just for people in services, but also for people delivering services, and also for people who may not be delivering services, but are definitely part of that foundational concept of trauma-informed care, like front desk staff, greeters when people walk in the door. They can all be part of trauma-informed care. Trauma-informed care starts with staff. It's the physical building. It's the first contact for people who come through our door. It understands that employees may also have their own lived experiences and personal trauma, and we need to support employees who are going to be working in this field and recognize that there are times that they may be triggered, they may be re-traumatized, and how do we support them? So really thinking about trauma-informed care as a foundation and not just about how someone delivers a service. Next slide, please. All right, core values of trauma-informed design. I want you to think about 6 human qualities that most people desire for physical and mental health in the places they inhabit. And when you do this, I want you to imagine, for example, in a place that you inhabit frequently, whether it be your office, whether it be your home, whether it be your yard, where you live. I want you to think about your favorite space. And what do you like about that space? It could be that your walls are your favorite color, or you have a favorite place to sit, or that it's really quiet. So those are some of the things that I want to talk about implementing in spaces where people in services and the employees that provide those services are going to be. The qualities that people desire are connection and community. You want to feel that when you walk into a place where you're going to be working on your mental health. Joy, beauty, and meaning, a peace of mind, empowerment and personal control, and importantly, safety, security, as well as privacy. Next slide, please. So I think it's very easy when thinking about implementing trauma-informed care, because there's been a push in Colorado and nationwide as well. We think about agencies that have to revise policy and employees that have to do tons of training or get a certification or rewrite plans, create trauma-informed care plans. And those implementations can take years if you think about change theory. And so I think I would like to encourage people to think about ways that are simple to implement. They take much less time and they can be done on a much smaller budget. These would be things like soft lighting or strategic lighting. And that would include, I have a young child who's terrified of the basement. Why? Because it's downstairs, there are no windows, and it's dark. Well, we have adults that don't like dark spaces, that they can be scary and re-traumatizing. So not having spaces that are dark, having well-lit parking lots, having well-lit stairways, the addition of artwork by people that are in services. So when you walk in, you can get a feeling of community because people who are in services or maybe providing services, their artwork may be in your agency. The creation of appealing areas to gather or comfortably sit. I think, and in later slides, we'll show you some photos, but areas that are appealing, areas that you would feel comfortable sitting in, that create a feeling of psychological safety or community. I initially put plants, but I think I'll revise that to say healthy plants. You want plants that are thriving, plants that are growing. Thinking about bringing the outside in with sunlight and plants helps create a feeling of psychological well-being. Something as simple as paint that is soothing colors. And that's something you can easily Google or just, trust your own gut instinct when you walk into a room or think about a room that you really love. What do the walls look like? What are the colors? Thinking about and implementing that, or even just taking care of a space with fresh paint instead of having old paint or chipping paint. Have something that looks like it's being cared for. As a therapist who specialized in trauma, it was always important to have grounding elements in my office for clients. Things like them being able to hold a mug of warm tea or hold something that had cold water in it. Something that's tactile can be very grounding for folks because it brings them to the present moment. So something as simple as having warm tea or cold water, having a soft surface to sit where they can feel their body in a space. Something as simple as that can be extremely grounding and comforting for people. Pleasant staff to greet people upon entering. If you've ever been in WellPower's, recovery center, when you walk in the front door in front of the elevators next to the front desk is a greeter, and it is, how are you doing today? Thank you so much for what you do. We're so glad you're here. I love that scarf. It's like the Trader Joe employee equivalent, right? You go in and there's just somebody to greet you and make you feel a connection. Something that simple can be really helpful for people walking into a door for the first time into services. It makes them feel welcome. It makes them feel connected, and it's less alienating. So having either front door staff or even people that are scheduling appointments at the front desk, just their affect and attitude can make a huge difference. And then something really simple, just reducing any unnecessary clutter, or, nobody wants to see a magazine from, 2010 on a table. So reducing clutter or any outdated materials, having materials that are fresh and don't look old and used, just shows that there is a sense of caring and nurturing for a space. Next slide, please. Okay, this is thinking even bigger, and this may be a little bit more long-term implementations. And this is where Joanne is going to shine. And really, I am just a conduit for all of her amazing information. She is really, we're very lucky to have her. She is really, I would say, nationally known as one of the experts for trauma-informed design. She was part of WellPower's architectural design for their buildings for trauma-informed design. And so I will let her speak after this slide, but just sort of a preview, thinking about buildings with hallways that are uncluttered and have space. So when you're walking down them, you don't feel contained or claustrophobic. Having a space for community in every agency, whether that be chairs outside or in a courtyard, or even the way that a lobby is designed, having a space where community can gather so that they can feel some connection. Again, lighting and windows, and if you're able to design a building from the ground up, having interior windows so that walls don't feel claustrophobic, particularly in, and I've noticed this in WellPower's buildings, the stairwells are not blocked in. As you're walking up and down the stairs, you can see where you are. You can see outside the stairwell. That could be a scary or triggering place for a lot of folks. So thinking about how to thoughtfully design spaces so you don't feel closed in. Having limited doors or not having doors where they aren't needed, which is in some of, I believe it's Sanderson's apartment buildings that you'll see pictures of. Using thoughtful and soothing colors in your buildings, bringing the outside in, which would be using sunlight, using plants, things like that as you can, to make buildings not feel so, again, claustrophobic or sheltered. Thinking, again, about strategically about the hallways and stairways, either having them well lit or having them designed to where they don't feel closed in. Reduction or elimination of blind spots. This is so important. I would say even in your outside spaces. So having well-lit parking lots, having well-lit paths for people to walk into buildings. And this is not just for people in services, this is for employees as well. Ensuring that you don't, there's not a fear that you're going to walk around a blind corner if possible. Again, having staff who greet, they're the first contact for people walking in to receive services. So ensuring that they make people feel connected and welcome. Having a space that just feels psychologically safe. And there are certainly ways that you can go online and research very concrete ways to do this, but I think too, it's sort of a gut check. When you walk into a building and scan immediately, how do you feel? Do you feel more at ease, or does it feel chaotic and unpredictable? Also, noise levels are taken into consideration. Loud and chaotic buildings can feel very overstimulating and unsafe. So finding a way to reduce noise levels. And then I don't want to ever forget the staff providing services, all staff, having a space for them to go and retreat as needed, to take a breather, to eat a snack, to drink warm tea or cold water, or feel connected to other staff members. But having a space just for staff is very important. Next slide, please. Okay, so these next slides, I want to say are Joanne's. They are property of Well Power. They have come from national presentation that she's done on trauma-informed design. So I'm going to let her go through and talk about some of these spaces, but these are projects that she has been a part of, and these are Well Power's buildings. So I'm very excited to let Joanne take the reins here and talk a little bit about the design here. And on the intro slide, I think maybe not all of her credentials were there, so I can let her introduce herself.
Oh, that's fine. I'm Joanne Toney with Well Power, formerly the Mental Health Center of Denver. If you look on the white paper for our proposed wish that trauma-informed design will be an evidence-based practice, that ShopWorks is doing some work on. The Mental Health Center of Denver was the person who introduced it actually to them. And we feel very proud of it, and also feel that every person that lives with us deserves the best we have. And we believe that trauma-informed design is part of that rollout. This is the Sanderson Apartments. I don't know if any of you have been there. We've had many tours. We have been open almost 7 years. We were granted LIHTC funding. That was a wonderful gift. We are in process of doing the updated version of Sanderson at the 10th and Sheridan property, where we were granted LIHTC funding again, and it should be open in about a year. So we're very happy about that. We've learned a few additional things with Sanderson. We wanted the beginning of this building right here, the main entrance. We wanted it to wrap its arms around people, welcome them home, and provide safe and sanctuary outside space. We believe that the people we serve are more apt to be harmed in the community than be the people who are harmed. So we wanted them to have a place where they could be outside and feel very safe, secure, and have a place of their own. So that's that. In here, you'll see our front lobby. Our front lobby has a white light well right in front of it. It goes all the way to the top, bringing the light all the way in. If you notice here on the main entrance, again, it's hard to see, but there's pieces of the building that jets out into the front entrance area and in. So that is so that people can see back and forth. They can see outside, see what's going on, assess whether it's a safe activity, if it's something they want to engage in. Is anything, unsafe happening there? And that's that line of sight that Kelly talked about. The people we serve want it, and the staff wants it. So we're always looking for a line of sight. Our hallways are connected all with our front lobby area. Our open stairwell goes up over here on the side. That's designed so lots of terrible things have happened to people in closed stairwells. This building, we knew we were going to be housing the people from the social impact bond. 60 of those individuals, where we went to the street, found them and homed them right here on off meds. Some of them had problematic use disorders. Today, 60 individuals live here, and 83% of this building is employed or engaged in vocational activities. It speaks to trauma-informed design working. It mitigates anxiety and helps people live safely, and therefore they're more apt to engage with us. Next slide, please. This is a closer look where you can see the color that we've engaged. We use the color of outside in because we knew that our target population here really were homeless. Many had been homeless 10 or more years, some 15 or more years. So we wanted them to feel completely comfortable in our space. This is our safe courtyard. It's all contained here. Some of the individuals we brought in weren't quite ready to live inside, so we didn't want to lose them back to the street again. So we had them unroll their bedrolls and they could sleep outside here, and staff still could see them. All of this glass is in the line of sight of staff if they needed us. And we don't have anybody today that's sleeping outside, but in the beginning we sure did. You'll see how our hallways are stepped out. There's a gradual step out. We're at where the front desk sits in front of that hallway. These units on this floor they all have their own porch light. This is their own individual doorway, and they're all color coded. Each floor is coded a different color. This is green, we have eggplant and a few other colors. And we do that to help people mitigate their anxiety. And I can see if I lived in that end apartment, I could see that I would be safe getting home. We also don't have to have our staff at night walking up and down the hallways because they have, not only is it cameraed, but they can see. Oftentimes, a lot of footsteps outside people's doorways are very problematic in helping people feel safe and secure in their own unit. So next, please. So here's a library. It's empty here. It is filled with books at this point. We've had many donations. Those books go in and out constantly, but we always have books. We have window seats to read in. This is a great room we have a fireplace there. This was taken before our board of directors stocked our shelves. But our furniture here is intended to be one opportunity for people to have conversation together. And if they didn't want to be too close, they could be in a window seat. And it's also across the hall from the community room, which is here, which is connected by the front TV that goes to out to the front desk area. This the other wall of windows with the window shade goes to the street. Some people are more comfortable in a room if they have traffic noise. And then out the front side of that building above well power, there is windows that lead out to that safe courtyard, and all of it is connected to bring the outside in and for people to feel comfortable with line of sight throughout the building. This is our event space. We use it to help people who may need just a little help warming up. Maybe their dinners, maybe we'll host birthday parties there. There's a lot of celebration over sporting events in that room, and a lot of screaming and yelling when Denver is losing, I might add. But we have some people who move in that just don't feel comfortable warming up their food in the microwave or on their cooktop yet when they first move in. So staff will help them here. And our hope is that they invite us into their units where we can help them then utilize their own equipment in their units. But you will see that there's all sorts of different arrangements further down in. There's different table shapes. Some of them are square, some of them are round. There's chairs close in. There's 1 or 2 chairs at some tables, more chairs at others. And they're all situated with their backs to the window, facing doors, all the things that we could think of, and the residents helped us think about how can they feel the safest in a room. Next slides, please. So these are 440 square feet. We do not have cupboard doors on any of our cupboards because looking and being able to see inside things is paramount for people to feel safe. We also can stand right by that kitchen there. That's where their front door is. We can see in that whole unit by standing in their doorway, so we don't have to enter. We wouldn't want to be intrusive, and we wouldn't want people to feel unsafe about us entering their units. Their bedrooms do not have closet doors on them for intended for the same thing, how they feel safe. In all different areas. Underneath the beds, you'll see our beds are up a little bit high. If we have a person who need it lower for health reasons, we can take some of that leg length off so we can lower it. But we start high so that people can see underneath their beds and know that things are safe under their beds. All of our furniture in these units are bed bug resistant. We, in the 7 years we've been open, have not had a bed bug outbreak, and that is a celebration, let me tell you. But all of our furniture also will support 350 pounds. If you sit on the edge of the couch and it falls off, we can order a new couch arm to go right on that couch, which then helps us with sustainability. The mattresses have a soft side and a firm side, and they're bed bug resistant as well. And so they can flip it to where they're more comfortable because we all have different likes and dislikes. You can see in the bottom right, you can see that there's an opening towards the window between the bedroom and the front room, and there is no bedroom door. We did that with purpose so that individuals could feel safer sleeping in their bedrooms and still have line of sight to their front room. If they heard a sound, they could just look out there and it would help mitigate that anxiety, that fear. In the people we serve at our Housing First programs, which Sanderson is, and these aren't my numbers, but people who have problematic substance misuse in community mental health and require case management services are about 98% of that population are trauma survivors, they have PTSD, mostly stemming from early childhood. This is their restroom. And we do have a door in their bathroom, as you can see. It is the only door inside their units. And this is really nice because you'll see that we've tiled up, and really we can just hose down these restrooms if they need a little help cleaning, which many people do when they're coming outside in. And so it makes it much easier. We encourage people to ask us for help, and we do help with that. Next slide. And then there you go. Any questions? I might have went over, sorry. I tried to hurry.
No, Joanne, you're not over. Thank you very much. Thank you, Kelly. There is actually one, I think there's one question in the chat that I think we could answer immediately. And that is, the question is, there's no doors going into the apartments. Is that right?
From the hallways in, there are doors.
Okay,
And
that's what I thought. I wanted to be sure and let you answer that question. So each apartment has a front door. Yeah, great. Thank you very much. Such good information and such a wonderful real world example.
Thank you so much for your time.
All right, thank you. Okay, our next presenter will be brief. Jessica Bell is one of our program managers for 2765 here at the BHA. So she's going to give us some updates on M1 emergency mental health forms.
Thanks, Paul. As Paul said, I'm Jessica Bell, Associate Director for the 2765 unit. Pronouns are she and her. Just wanted to give everybody that update. I know M forms has been a hot topic lately, and I wanted to make sure everybody knows they are all available in draft form on our website. The reason for that is we missed a critical step, and so we kind of brought them back a little bit. We wanted to make sure everybody had an opportunity to review the forms and to provide any feedback or concerns, or if we're missing anything that they have. So there is a feedback survey, and you can access that survey from now until the end of September. So a week before October 1st, I will pull that survey down so that I have that last week in September to finalize all the forms, get them through our AG's approval. And then starting October 1st, those will be finalized and be put back up on the website. From October 1st until the end of the year, we will be providing any kind of training related to those new forms, especially patient rights, because I know that has been a really big concern for a lot of providers, given that the new cell phone requirement. So also we have a 2765 training request. I will say we're not reaching out to schedule those trainings just yet. We are going to wait a little bit longer, and it will be closer to the end of September when we start scheduling those. But by all means, if anybody has any questions or any feedback, I'm going to put the links in the chat. You can fill those out. You can also email me directly, and I'll put my email in the chat also. And that's all I have. Thanks for letting me drop in my message really quick.
Thanks, Jessica. I'm sorry I got your title wrong. I
It's okay.
obviously did not look at the updated information. And there's a question in the chat. Jessica, do you want to take that? Would you clarify if the new informs can be used?
Yes, so when they're finalized, you can begin using them. So that would be October 1st. And then everybody needs to be switched over by January 1st when the new rules and the new laws go into effect. Training requests are for anybody. There's options in there. You can request it for yourself. You can request it for your agency. There's different topics you can request if you want specific to M forms, if you want specific to the new 2765 rules that are coming out. There's also another option, and we can talk more when we reach out to schedule that, what exactly you're looking for. We offer in person, we're going to offer virtual, we're going to offer a hybrid option. So we will make sure that we're getting the messages out to everybody that needs them or wants them.
Thanks, Jessica. Okay, we can go to the next slide. Kasia Switkowski could not join us today, so I'm going to give a quick update on the block grant application. So for fiscal year 24-25, the annual mental health block grant and substance use prevention, treatment, and recovery block grant is due to SAMHSA September 1st. The draft application is posted on the BHA website for the public to submit comments using a Google form. The opportunity to provide feedback will be open until August 23rd, and there is a link to the draft application where you can provide comments. Okay, next slide. So just want to give some information about how to engage with the BHA. These provider convenings occur on the third Thursday of the month bi-monthly, that is every 2 months. So the next meeting will be October 19th. And there is the website to our BHA engagement calendar. And the next slide just gives us information about how to engage and connect with the BHA. And I want to check the chat and ask if there's any questions. Those helping to cover the questions if we need to answer any at this time.
I think Summer answered it for us, Paul. There was one from Elizabeth Richards.
Great, thank you. So the BASO request for information is expected to come out by the end of August, and it will be on our webpage. Any others? Okay, we are well ahead of schedule. So if there's nothing else, we get to end early, and hope everyone has a great rest of your day. And thank you very much for joining us.